Doctors, myself as Dr. Monu Nain, PG resident in MS General Surgery at GMC Jhalawad, Rajasthan. Today our topic of discussion is GERD or GORD, Gastro Esophageal Reflux Disease. Like previous video, the information gathered here is from the Levent Bailey textbook of surgery, latest edition 28th. So let's start the discussion. First of all, after watching this video, you will know all about the GORD, like what is the etiology of GORD, clinical features, complication, diagnosis, management and treatment. Management part include two subheadings: investigation and treatment. So in GORD, basically the full form gastroesophageal reflux disease. So what happened? This is our esophagus and this is the stomach, and here is the LOS, lower esophageal sphincter. So what happened in GORD? There is relaxation of lower esophageal sphincter, and this acids reflux into the esophagus and cause the symptoms to patient. So here the definition: condition when the reflux of stomach contents cause symptom or complication to patient. So this is the definition of GORD. And what are the etiology? So as mentioned earlier, here the relaxation of lower esophageal sphincter or hiatus hernia. So what is the hiatus hernia? In hiatus hernia, the gastric part, like stomach, below the diaphragm, herniates through the diaphragm opening into the thoracic cavity. So the stomach herniates to thorax. This is known as the hiatus hernia. Now what are the causes of hiatus hernia? Aging can be one cause, connective tissue disorders, or elevated intra-abdominal pressure. So what causes the elevated intra-abdominal pressure? Here, like obesity, pregnancy, ascites. All these things cause elevated intra-abdominal pressure, which in turn cause hiatus hernia and which is responsible for GERD. So hiatus hernia can be a risk factor for GERD. This is the one thing. And now, what is the protective factor for GERD? H. pylori. H. pylori infection has protective role. How? Let us assume this is the stomach. After the H. pylori infection, there will be atrophy of gastric cells. So H. pylori cause atrophy of gastric cells, which leads to decrease production in HCl and decrease the risk of GERD. And GERD cause esophageal adenocarcinoma. So this can be a potential question in upcoming NEET, that GERD is a risk factor for esophageal adenocarcinoma. So this is the one point to remember here. H. pylori protect the patient from GERD, and GERD is risk factor for esophageal adenocarcinoma. So now what are the clinical features of GERD? It includes two subheadings: esophageal and extraesophageal. In esophageal, it causes heartburn, like burning pain, retrosternal. Behind the sternum there are burning sensation. And in regurgitation, what happens? The gastric contents comes to oral cavity. So this is the definition of regurgitation. Epigastric pain, which can be due to the erosive esophagitis, because the HCl causes the damage to the mucosa of esophagus and leads to erosive esophagitis. And there can be dysphagia. The dysphagia can be due to the presence of stricture or due to the hiatus hernia, due to the compression of esophagus. And this erosive esophagitis can cause hematemesis. And the second cause of hematemesis in GERD patient can be esophageal carcinoma, which is the complication of GORD itself. And there is risk of Cameron ulcer. Cameron ulcer. Now what are the Cameron ulcer? So here you can see the hiatus hernia in this picture. This is the diaphragm and the stomach herniates through the hiatal opening. So this part of hiatus hernia, in this cavity there are ulcers which are known as the Cameron ulcer, which are the most common with the paraesophageal hiatus hernia. What mean by the paraesophageal? Like here, this is like this is the stomach and this is the pouch. In hiatus hernia there is a pouch besides the esophagus. So this is known as paraesophageal hiatus hernia. Due to the pressure and necrosis in this part, there is formation of ulcer which is known as the Cameron ulcers. So this is about the esophageal clinical feature. And what are the extraesophageal? Due to the chronic irritation of the pharynx and larynx by the HCl, there are some features, extraesophageal features like chronic cough, laryngitis, asthma and dental erosion, blackening of teeth in patient of GORD. So these are the clinical features and complications of GORD. So symptoms of GORD aggravated by the food intake. So what is the significance of this simple line? Because the patient of GORD has two differential diagnoses, MI and gastritis. So differentiation between these two can be done by this simple point. In MI there is history of epigastric pain with nausea and vomiting, and in gastritis there is burning pain with घबराहट. So if the pain aggravated by the food intake, then we can think of gastritis and GERD. Now we came to the diagnosis part. So in GERD, in most cases, the diagnosis is assumed rather than proven. So in most of cases, the diagnosis made on the basis of history part only, and the treatment is empirical. Empirical means PPIs. PPIs are the first line of drug for GERD treatment. And why we do some investigation here? So there are role of different investigation in patient of GERD, not for the diagnostic purpose, but some other relevant complication. So we have to do upper GI endoscopy to know about the complication of GORD and to rule out these three differential diagnoses on the basis of upper GI endoscopy, like eosinophilic esophagitis is one DD of GORD, esophageal motility disorder like achalasia, and esophageal cancer. So to rule out these three from the GORD, we can do the upper GI endoscopy. And the second investigation is ambulatory pH recording. Here we put a probe 5 centimeter above the LES, lower esophageal sphincter, to know the pH here. So this investigation is known as ambulatory pH recording if the patient having symptoms despite the proton pump inhibitors. And the third investigation is high resolution manometry. What is the role of high resolution manometry? It is done for esophageal motility disorder as discussed, like achalasia, and for the location of to know more about the location for pH monitoring, and for the assessment of LOS function and morphology, and to plan an anti-reflux procedure like Nissen, fundoplication, etc. We will discuss about these surgery more in the next upcoming slides. So there is a DMISTER score. DMISTER score is based upon the ambulatory pH monitoring investigation. Here we measure the pH in the lower esophageal sphincter part, and for this investigation we keep the patient proton pump inhibitor free for 2 weeks. We don't give proton pump inhibitor before 2 weeks of this investigation. So there is a score calculated. If this score comes 14.7 or more than 14.7, the patient is diagnosed with GORD. So this is the Demister score, and this is the investigation showing the pH ambulatory monitoring. So this is the graph which can be asked in upcoming NEET PG by giving this image. So what is the management? So the management of GRD depends that patient has complication or not. If the patient has uncomplicated GORD, then the management depends on lifestyle modification. So first of all, we tell the patient to avoid overeating any alcohol, tea or coffee, because these three things irritates the gastric mucosa, and to avoid oily and spicy food. How this affects the production of HCl? These two factors, oily and spicy food, inhibit the gastric emptying. So the HCl accumulates and cause more damage to gastric mucosa. So these are the reason behind these factors. So we will tell the patient to have early dinner, at least 2 hours before going to bed, and elevation of fat, and patient should be advised smoking cessation and the weight management, because obesity is a risk factor for hiatus hernia, which is a risk factor for GORD. So these are the lifestyle modification and their reasons. So what we have in medical management? In medical management we have antacid to neutralize the HCl already present in stomach, and PPIs for 8 weeks, and then we taper them. PPI inhibit the HCl production, and there are H2 receptor antagonists like cimetidine or ranitidine, and there is a new drug in the market which is known as potassium CAB. They block the potassium channels. What is the advantage of these over the PPIs? Because they are more rapid than PPIs, and they inhibit the hydrogen potassium pump competitively in reversible manner. So this is the medical management. Now we came to the complicated GERD, in which there are complications. We already discussed the complication of GERD. So in this patient we will go for surgery. So what are the indications for surgery in GERD? Like failure of medical management and intolerance. Patient is unable to tolerate long-term PPIs. And if there is presence of large hiatus hernia, and if it is complicated GERD, and the patient has extra esophageal symptoms like cough, laryngospasm, and there are dental caries, etc. So in this patient we go for fundoplication. So these are the 4 types of fundoplication surgery. First of all, what is the fundoplication? Fundoplication. In fundoplication we cause a floppy wall around the gastroesophageal junction and restore the angle of his. So these are the 4 types of fundoplication. This is the question asked many times by giving this picture in NEET PG. So this is the typical stomach picture. First of all, this is the picture, and this is the angle of his. So in Nissen fundoplication we wrap the stomach 360 degree around the esophagus, and in Toupet we wrap the stomach at 270 degree, and in Door at 180 degree. Door is anterior fundoplication and Toupet is posterior fundoplication. So these are the 3 types of surgeries usually performed in patient of GERD. So what are the advantage and disadvantage of these surgery? In Nissen fundoplication, due to the 360 degree rotation, there is short-term dysphagia, like for 3 months. There is a risk of dysphagia, but there is very less chance of recurrence of GERD. So this is the most durable surgery, and it causes gas bloat syndrome. The patient will complain of bloating and flatulence. So this is the gas bladder syndrome. And in partial fundoplication includes Toupet and Dor. There is less dysphagia, but there is a high rate of failure. So these are the advantage and disadvantage of these surgeries. So this is the picture of pH ambulatory monitor. This is the probe placed in esophagus for pH monitoring. And there is a picture of HRM, high resolution manometry. So this is the picture which can be asked in upcoming NEET PG. As I have discussed, the source of information gathered in this video from the Love and Bailey Book of Surgery, latest edition 28th. So this is the all about the GORD. If you have any doubt, please ask in comment section, and do not forget to subscribe our channel and keep sharing, keep loving. We will upload more content